ask you, Dr. de la Rosette, what is the point about treating with focal therapy or with energies a recurrence? I mean, won't you go for a prostatectomy, for instance?
It's an option.
And what is the benefit with those energies that cannot offer a prostatectomy? Because the results, I think the outcomes were similar to prostatectomy.
Let's ask it like this. So, in the room here, can you raise the hand if you are a urologist who does radical prostatectomies? Can you raise the hand? Okay, good. How many of you do salvage prostatectomies after radiation? A lot. Good. And who is doing implants for incontinence after salvage prostatectomy for radiation recurrence? All of you. Yes, good. So having said this, whatever you offer to the patient, it looks bad. Surgery or whatever. And then you have a less invasive treatment. And if you want, you still can go for surgery. But then even the side effects will be more. No, but seriously, at our place, when there was a recurrence, we send the patients to another hospital where they had specific expertise in doing this. And they afterwards often came back for their incontinence surgery. So it's a significant problem. It's a big group. And I think we should carefully have a look at this. I don't say we should offer to everybody, but we should properly study it.
Thank you.
You're welcome.
Just to say that we have some radiotherapy oncologists here, and there is a shift in our attitude because I remember when we said that it was easiest to follow prostate cancer if you go for a prostatectomy than with brachytherapy. Now we are changing a little bit the point of view. Thank you.
It's a very nice talk by Jean. I'd make 2 points. Firstly, we get radiotherapy failures late, and if there are any radiation oncologists here, then really as soon as they hit biochemical failure, they need to be referred in for potential local salvage, because the earlier the better, the tinier the lesion, the much better outcome functionally and oncologically. And the biggest problem is actually patients presenting late. Their PSA has reached 10, and then the oncologist refers them on. Or, and again, this is my colleagues in oncology misbehaving. They are not referred on because they want to start them on systemic therapies or put them into trials. I'm surprised that the chair of the former chair of urology at Amsterdam doesn't know the different types of sexual therapy sexual function that might be going on that people partake in. But I won't give him a lesson. Maybe 50 Shades of Grey. Maybe read it or watch it. So I'm going to talk about focal therapy for high-risk disease. And obviously, high-risk disease includes salvage, but I'm not going to talk about that. I think when we're talking about different risk groups, then we have to understand why local ablation should fail. You know, how is it that cells can resist -40, -60, and some of the cryoprobes that we stick in now go down to -100, -120, or other cells can resist temperatures of 80, 90 degrees centigrade, which is able to boil tissue. And clearly there are limitations in delivering that energy with the ablation device. There are characteristics within the prostate itself which are around selection, so calcifications and cysts, which might deflect the energy, particularly with HIFU. There are tumor sink issues, so the characteristics of the tumors themselves, as well as failure resulting from untreated tissue, from new lesions that develop, or untreated Gleason 6, if you believe it, progresses to Gleason 7. And obviously when we're talking about salvage group and high-risk group, we're also concerned about metastatic disease, which you won't be able to do much by using local ablation, or we don't think so anyway. So I'm going to focus on things that are tumor characteristics, which are related to risk, and distant failure, which is also related to high-risk disease, and our workup. So I think we're getting better at ruling out metastases. We, in the past, only used cross-sectional CT or radioisotope bone scans, and increasingly with choline PET, PSMA PET, whole-body MRIs, we're starting to detect tiny metastatic lesions that we were missing before that would have then declared themselves after local treatment, whether that local treatment is radiotherapy or surgery or focal therapy. And so as we get better at ruling out distant disease, we might be able to select a group of men with high-risk prostate cancer, which is truly localized to the gland and would not fail after focal therapy due to undetected micrometastatic disease. So we're seeing a stage shift, and we can't compare data in the modern era of imaging to the era prior to modern imaging. And we are starting to see a risk shift as a result of using targeted biopsies, and a stage shift as a result of staging not on the basis of a finger, which is what the D'Amico risk classification is based on, but based on MRI staging, which I think is overcalling T3 disease often. So this is an example of what we would normally get with a systematic biopsy. We often biopsy the periphery or get a near miss on the lesion, and that tumor would come back as 3+4, significant disease that needs to be treated. But if we then subjected that same man to a targeted biopsy, directly hitting the tumor, we would get a maximal Gleason 4+4, and we are increasingly seeing this happen in our multidisciplinary team meetings, and my colleagues in radiotherapy and surgery are saying this is a 4+4 tumor, not a 3+4 or a 4+3 tumor, and therefore should be treated very, very aggressively, even though it's a tiny lesion. And this is the wrong approach. This man still has an overall lesion score of 7. So we have to be very careful about our interpretation of targeted biopsies now. We showed in this simulation study the same thing happening, that if you used truss biopsy compared to image-targeted biopsies, the same cases would be classified higher risk with targeted biopsies, like for like. So as I said yesterday, we really have to get rid of all of our risk classification models and start all over again. And there's a stage shift with MRI. We often get my colleagues in radiology now calling these capsular abutments and capsular enhancements as likely T3 disease, or microscopic T3A likely, and we have to be very, very careful when these men in the past would clinically be only deemed T1 or T2, and on imaging now are being called T3A. And I would argue that this man was suitable for focal therapy, and we certainly are treating them, provided they only have a certain amount of capsular abutment. And his PSA response was very good, and he remains disease-free. But do we have any overall data? So the cryotherapy registries are quite good with this. If you look at focal therapy across low, intermediate, and high-risk disease, remarkably, the graph on your right shows no differences in biochemical outcomes between full gland and focal therapy by risk category. This is quite a bizarre thing to see, but it's nonetheless the data that's presented here. This is a series that I showed before. This is our own series. There are bigger series out there in the literature, but the unique thing about this series is that we selected very big tumors that were often T3 on imaging, that were high risk on NCCN criteria or intermediate risk disease. And short follow-up, but, and this is just one case, this is a typical case, an MRI with an anterior lesion, which was then treated, which was then biopsied, found to have high volume Gleason 7 disease and had image fusion cryotherapy. And then his post-treatment MRI showed absence of perfusion in that area, quite a large volume ablated. And our early results, at least, show that very few of these men fail and go on to have salvage radical prostatectomy. Some of them do need further focal therapy using cryo. This is our 625 men who've had focal HIFU, of which 189 were high risk on NCCN criteria. And you can see here the low risk obviously do much better. Failure was defined by transition to salvage radical prostatectomy or radiotherapy or systemic therapy or METs. Nobody died in this series from prostate cancer, but death was part of that composite definition. And there is no difference between intermediate risk disease outcomes and high-risk disease outcomes using this composite definition. There were about 5 to 10% more men in the high-risk category who required redo HIFU, which I haven't shown on this. So I think in conclusion, the treatment of prostate cancer is increasingly shifting to higher risk cases as we start to see with imaging, either whole body imaging by using whatever modality and multiparametric MRI, that this is leading to a grade, stage, and risk shift. We are starting to see a Will Rogers phenomenon across the board. Therefore, for selected cases which are amenable for focal ablation, carefully selected, treatment of high-risk disease might be a very rational strategy. Thank you very much.